Ma'am, good afternoon, ma'am. Sujata, ma'am, we are not able to hear you.
Yeah. Good afternoon, one and all. I'm glad to invite you all for the 33rd edition of Changai Pediatric Week. IAP Chengalpet. And without wasting much time, we will go to the program. We have got four case discussed presentation. The first one is when autoimmunity hits the kidney heart by Dr. Manikandan with the moderator as Dr. Sunita from Chetnod Hospital and Research Institute. Over to Dr. Manikandan.
Good afternoon, everyone. Am I audible? Ma'am, am I audible?
Yes, sir.
Are my slides visible now?
Dr. Manikandan, your slides are visible.
Thank you. But when automatically it's the kidney heart, raise topic as well. Yeah. We had a case of 13-year-old female child who was from Kenavara, was brought by her mother whose relativity was good. With complaints of lower abdomen pain for 4 days and complaints of passing blood and urine for 4 days and vomiting for 4 days with puffiness of eyes, swelling around the eyes for 2 days. The lower abdomen pain was dull aching, non-radiating and intermittent nature, not associated with burning exudation, increased frequency or exudation or constipation. Vomiting, she had 2 to 3 episodes of vomiting per day, which contained food particles, not bilious or menstruation. The passing of hyperurine was present, which was painless in nature. Swelling around the eyes was with swelling of lips. No history of yellow discoloration of skin or eye was present. No bleeding manifestations in the child. No history of fever, sore throat, or any infections in the past. No history of drug intake or any insect bite or trauma, and no history of skin rashes, joint pain, or joint swelling present. No history of respiratory distress or recurrent respiratory tract infections, and no history of loss of weight or weight was present in the child, and no history of neurological deficit seizures and altered sensorium was present. No history of chest pain, palpitations, or breathlessness was present. These were asked to rule out the complications of the problem. During this history, the child was taken to a local hospital for the severe complaint, where she was treated symptomatically and was referred here for further management. Past history, there was no similar illness in the past, and there was no brief hospitalizations present. Ultimately, the child was first born out of a third degree consensual marriage, and there was antenatal history was uneventful. The birth history was a full-term delivery with normal delivery, a birth weight of 2.5 kg. Baby carried immediately after birth, and there was no any admissions. Developmentally, the child is studying class 8 with a good scholastic performance, and immunization, the child was immunized till 10 years of age after NAS and no additional vaccine. Family history. There was a history of population of eyes and transient proteinuria present in the younger sibling, around 1.5 years of age of the younger sibling, for which she was treated on OPD basis, and spontaneous remission was resolving of the symptoms are present, and no recurrence or medications were taken. And no history of any other renal disorders in the family, and no history of tuberculosis in the family was present. The pedigree chart, she was the first one out of 38 consanguineous marriage. Social economic status, the child, according to modified Kusami scale, the child, the family comes under the lower middle class family. Dietitian, she had an intake of 1,050 kilocalories against an expected of 2,000 kilocalories, the deficit of 250 kilocalories, and a protein intake of 40 grams against 44, which the deficit of 4 grams. Summary: 13-year-old female, first one of 30 years of marriage, who was with uneventful antenatal history and birth history, developmentally normal and immunized according to 10 AS. Presented with complaints of lower abdominal pain, vomiting, high colored urine, and puffiness, swelling around the eyes with acute onset, which with no significant past history. So this suggests this probably suggests a cause being related to the renal origin, most probably UT or nephritic syndrome. On examination, the child was conscious oriented and pallor was present with bilateral pedal and puffness around the eyes. No other significant examination finding was present, and the normal BP of 110 to 70, which fell under the 50-90 centimeter. Head to examination, bilateral 15 pedal edema was present with puffness of eyes was there. And other systemic, there was no restriction of abdomen and no other systemic examination finding was present. Anthropologically, the child had a normal anthropometric instruments. System examination, child was examined supine position flex knees. Abdominal examination showed normal, and there was no significant abdominal history. Inspection findings are normal, and percussion palpation showed no organomegaly with reverse span of 7 centimeter. Other systems were within normal width. So we had a differential diagnosis of UTI and nephritic syndrome, and evaluations were indicated further towards that. On investigation, the CBC showed normal growth, the anemia was present, and the urine protein showed with 2+ albuminuria with plenty of RBCs and pus cells. So we suspected UTI, and the child was immediately started with IV antibiotic or ceftriaxone, and nephritic workup was also done safely. The further workup showed hypoalbuminemia and serum creatinine the rising trend of 1.6, 1.7, and 2.98. And spot PCR was also increasing trend, and ASO was negative. Urine cultures became normal. So we this suggests to rule out UTA and the primary nephritic syndrome, which made us to evaluate for the secondary cause of nephritic syndrome. Most probably immunological work was done. Which showed ANA of moderate positive and dsDNA of weak positive with low C3 levels. And we planned, since there was an increasing trend in the serum creatinine levels and the kidneys were failing, the GF or 30, we just planned for biopsy when the workup was done. And the biopsy showed immunological deposits in the glomeruli. The first one is immunofluorescence stain, which shows the C1q deposits, and C3q deposits are also present with fluorescence effect. And the second one is Mason trichrome stain, which showed immune flux deposition. The report was that it was more suggestive of membranoproliferative nephropathy, and with immune complex mediated deposits were there. And nephrologist opinion was obtained, who suggested this to be grade 3/4 nucleus nephritis, first episode. Post biopsy, the child had decreased urine output, for which the child was started on diuretics. And based on the diagnosis, we started the child on IV methods, prednisolone. Pulse therapy was initiated for the first 3 days, which later changed to oral steroids. Along with microphenolate was started with hydroxychloroquine support under the cover of antibiotics. Discussion part. The lupus nephritis is caused mainly due to genetic and epigenetic factors in individuals who are already predisposed genetic, who has HLA-DR4 and HLA-DR11 predisposed to genetics. And when a trigger accelerates stress, epigenetic factors come into play, where methylation or histone changes results in loss of immune tolerance to the body, which hits the kidney. The main mechanism of damage to the kidney is due to immune complex deposition, and also direct activation of the innate immunity through the form of plasmacytoid nephritic cells. This activated damaged renal tubular epithelial cells also act as an antigen presenting cells and further trigger the cascade pathway, which lets the tubular epithelial cells turns into an APC and which produces BAP, which is a B cell activating factor, and starts producing tertiary lymphoid structures such as in layman's terms like lymph node in the kidney, and starts producing further immune system activation, which leads to deposition of immune complex and direct damage to the glomerulus. Clinical presentations. Most common presentation is asymptomatic hematuria alone can be present with mild proteinuria. Nephrotic or nephritic mixed picture can be seen with hypertension. Renal tubular acidosis can be present in the form of acidosis, acute or chronic kidney injury, or RPGA. The grades of classification of lupus nephritis are classified into under 6 grades, with minimal mesangial lupus nephritis being the grade 1, and grade 2 is mesangial proliferative lupus nephritis, and grade 3 is focal proliferative nephritis, which means less than 50% of the glomeruli are involved, and grade 4 is diffuse proliferative lupus nephritis, with more than 50% of the glomeruli is involved. Grade 5 shows membranous lupus nephritis, and grade 6 is the worst among all this, which shows advanced sclerosis. More than 90% of the glomeruli is sclerosis. Therapeutic guidelines. This therapeutic or the goal treatment, all of the treatment is mainly to preserve the kidney function and prevent disease flare-ups. The most commonly used is induction. Start of the therapy, we use induction treatment, which was 3 to 5 high doses of IV methylprednisolone pulse therapy. The dose of 500 to 1000 mg per meter square per day. It is followed by oral prednisolone 1 to 2 mg per kg per day for 2 to 3 doses. Which is slowly tapered over 4 to 6 months, beginning 4 to 6 weeks after achieving physiological remissions. Maintenance therapy involves IV cyclophosphamide 500 to 750 mg per meter square every month for 6 months, and then every 3 months for 18 months. This reduces the risk of progressing renal dysfunction. But in this case, we didn't use cyclophosphamide, given the side effect of infertility and gonadal toxicity. So instead of that, other steroid sparing agents, one among them, mycophenolate was used. These other drugs can be used for maintenance therapy, such as MF, azathioprine, cyclosporin, tacrolimus, and rituximab can be used. In case of in failure to immunological therapy, or the grade 6 of lupus nephritis, where immunomodulators doesn't work, renal replacement therapy is the other option, with end-stage renal disease requiring renal transplant. Prognosis of lupus nephritis is usually 80% for around 10 years of survival. But these factors, such as early age of onset or male predominance, male gender, hypertension, nephrotic syndrome with anti-dsDNA positive, and elevated serum creatinine more than 3 mg per deciliter, and delay in starting of the treatment, or poor response to 1 year of treatment are factors which determine worse prognosis. The newer drug that are being approved by the FDA in recent times are voclosporin, which is a calcium inhibitor, which was approved in the year 2020 by FDA. With this inhibits in the calcium inhibitor, which improves kidney function and can be used as adjunct therapy along the standard therapy. Elimumab, which was BL, which was approved in 2023, the latest last one to be approved. The monoclonal antibody which targets B cell activation and slows the progression of the disease and helps in lupus nephritis. Thank you.
Thank you, Mangalam, for the excellent presentation. I just want to know from the moderator, how long you need to continue all these drugs? You have started prednisolone, started mycophenolate, and hydroxychloroquine.
Actually, we give prednisolone as a pulsing dose of 3 to 5 days, and we continue with low dose steroid. It depends. Actually, we have low dose, moderate dose, and high dose steroids. where only the dosing differs. It starts from 0.3, we can go up to 1 gram per kg per day, and we usually give it over a period of 3 to 6 months of prednisolone. And coming to hydroxychloroquine, we continue it lifelong for the child. Actually, that reduces the instance of relapse and reduces the renal damage. So we usually prefer to give, we continue hydroxychloroquine. And why microcranial mofetil is considering the risk and the benefit, we considered enough over cyclophosphamide, especially she was a female child, adolescent female child. We wanted her ovarian reserve to be preserved. So the main side effect of cyclophosphamide, ovarian failure, gonadal failure. So we preferred MMF. And the recommendation says we start an induction of 3 to 5 months. We can go up to a maintenance of starting with 18 months, can go up to 3 to 5 years of maintenance dose also.
Thank you. The floor is open for discussion. Any other person?
Ma'am, it's a very worked up case. Um, uh, Actually, it's a question for the postgraduate. What if we are starting a cyclophosphamide and the child gets a hemorrhagic cystitis? So what will be the management in that case? Just for the postgraduate sake. Um,
Okay.
um, Ma'am, am I audible? Ma'am, your voice is not audible, ma'am. Sujata, ma'am.
Are you able to hear
I'm sorry, ma'am. Um,
me?
Ma'am, Ramya, ma'am, can you hear? Maybe, so the answer will be Mesna can be given. Maybe we'll move on to the next case if there's no further question or something. Thank you, ma'am.
If there are no questions for them, I go to the next topic. Acapella, Dr. Ponmuri, the moderator, Dr. Vijay from Melburgood, Adiparasakti Institute of Medical Sciences and Research. Over to Dr. Ponmuri.
Am I audible, ma'am? Sir?
Yes, you're audible. You may proceed.
Uh, Good afternoon, everyone. Welcome to Acapella from Department of Pediatrics and Neonatology, Mail Mavathur Adi Parashakti Institute of Medical Science and Research, under the guidance of Dr. Shivagami Sundari ma'am, HOD Pediatrics, presented by myself, Dr. Pon Molik Kumar, moderated by Dr. Vijay sir. Coming to our first baby, baby A, born to a 26-year-old G2P1L1 mother, non-consanguineously married, born at 39 weeks plus 6 days. Antenatal anomaly scan showed mild left renal pelvic tasis with no other abnormality detected in antenatal scan. Baby was delivered by normal vaginal delivery, cried at birth. Apgar at 1 minute was 8/10 and at 5 minutes was 9/10. On examination, baby cry and activity were good, vitals were stable. On systemic examination, no abnormality detected. On routine head-to-toe examination, left testis was large. On routine head-to-toe examination, left testis on routine head-to-toe examination, left testis was large, non-tender, hard in consistency, no swelling or erythema seen. Right testis was normal, in view of which USG scrotum with Doppler was done, which showed left torsion testis and right side scrotum mild hydrocele. Baby was diagnosed with prenatal testicular torsion. So here is the USG scrotum with Doppler of the baby, which shows right side testis, which is normal with a hydrocele, and left side torsion testis with central necrosis. And the Doppler shows left side testis, no vascularity is seen, and in right side vascularity is seen. Intraoperative findings, left testis was necrotic, no viable tissue was seen, hence left side orchidectomy was done for torsion testis, and right side orchidopexy was done with 3-point fixation. Post-op period was uneventful and baby was discharged the next day. A few words on neonatal testicular torsion. Any testicular torsion identified prenatally in utero or within the first month of life is called as neonatal testicular torsion or perinatal testicular torsion. The incidence is 6.1 per 100,000 live births. Occurs when the spermatic cord structure twists away from the midline in the direction of the cremastic muscle fibers. Depending on the degree of torsion and the venous drainage is initially affected, and then the arterial blood flow, resulting in ischemia and necrosis of the testis, leading to loss of function. Neonatal testicular torsion are of two types based on the tunica vaginalis. It could be extravaginal or it could be intravaginal. Extravaginal testicular torsion is when the spermatic cord, the rotation of the spermatic cord occurs external to the tunica vaginalis, and intravaginal, the rotation of the spermatic cord occurs within the cavity of tunica vaginalis. The extravaginal testicular torsion, the most common type is the most common type of neonatal testicular torsion of 85 to 90%. Of these, 60 to 75% occurs prenatally or during delivery. Often occurs during the testicular descent from the abdominal cavity into the scrotum. Intravaginal torsion is seen in later infancy and childhood. Bell clapper deformity is associated with this type of testicular torsion. Risk factors. The predisposing factors are hyperactive cremasteric reflex, cryptorchidism, epididymal abnormalities. The maternal factors could be preeclampsia, gestational diabetes, twin gestation, large for gestational age, presence of prenatal hydronephrosis, breech presentation, prolonged labor, and a difficult delivery. All these conditions could lead to increased intrauterine pressure, which will stimulate a brisk cremasteric response in the setting of loose tunic scrotal attachment. This will lead to testicular torsion. Most prenatal torsion occurs in full-term neonates. Coming to clinical features, the prenatal testicular torsion occurs before delivery. Usually the baby is asymptomatic at presentation. A firm, non-tender, discolored scrotal or groin mass is seen. It can also be difficult to palpate the testicles separate from the scrotal skin, as an inflamed testicular mass is adherent to the skin. Usually, the ipsilateral hemiscrotum is ecchymotic. Postnatal testicular torsion occurs postnatally and appears with more classic inflammatory signs of torsion such as swelling, erythema, or discoloration and tenderness. Management. One should explore the affected site promptly to confirm the diagnosis and to fix or remove the affected testicle. The differential diagnosis would be torsion of the epididymis or the appendix of the testis, tumors, inguinal hernia, cellulitis, and congenital hydrocele. In neonates, color Doppler sonography shows an enlarged heterogeneous testis with thickened tunica albuginea with a rim-like hyperechoic reflection calcifications at the transitional zone between the testis and the tunica albuginea. The hypoechoic central area may also be evident, which shows necrosis. Treatment. Treatment is surgical exploration and detorsion. Testicular salvage after surgery is as low as 6% in neonates and 17% in infants. The contralateral testicle is explored. Orchiopexy is performed by fixing the testis to the scrotum. Now coming to our next baby, baby B. Now coming to baby B, which is born to a primary mother at 38 weeks plus 1 day. Mother is a known case of gestational hypertension and the antenatal scans were normal. Baby was delivered by normal vaginal delivery. Baby cried at birth. Apgar at 1 minute was 8/10 and at 5 minutes was 9/10. On examination, baby cry and activity were good. Vitals were stable. On systemic examination, no abnormality detected. On routine head-to-toe examination, a tiny, firm, non-tender swelling adhered to the right scrotal skin with size of 0.7 centimeter was noted, able to palpate the right testis separately from the swelling, in view of which USG scrotum was done, which showed a calcific focus of size 0.3 into 0.2 centimeter noted within the right scrotal sac associated with right infantile type of hydrocele. X-ray abdomen was also done, which revealed no calcification. A diagnosis of meconium periorchitis was made, and the parents were counseled regarding the benign nature of this condition, and reassurance has been given. A few words on meconium periorchitis. It is an uncommon benign cause of a scrotal mass in the newborn. First, described by Onlick and Hatcher in 1953 in an infant with scrotal and peritoneal calcification. The differential diagnosis of a neonatal scrotal swelling would be hydrocele, inguinal scrotal hernia, testicular neoplasm, testicular torsion. Distinguishing meconium periorchitis from neoplastic swelling is crucial because it mimics scrotal mass, and without knowledge of this rare disease, it may lead to unnecessary surgery. Pathophysiology. Any in utero bowel perforation caused by thickened meconium in case of cystic fibrosis and other causes like bowel atresia, volvulus, or vascular compromise may lead to in utero bowel perforation, which will lead to leakage of the meconium into the peritoneum, which causes meconium peritonitis. Some bowel perforation heal without obvious sequelae, and the baby appears well at birth. But the meconium which was leaked in the peritoneum may reach the paratesticular soft tissue through a patent processus vaginalis and causes a scrotal mass. It is usually diagnosed in the first week or month of life. Initially, there is a soft hydrocele or soft scrotal mass, which later presents as a hard swelling as the meconium calcifies. Presence of abdominal calcification in addition to scrotal calcification strongly suggests the possibility of meconium periorchitis. The patient's age at the time of diagnosis of the associated mass varies, but patients typically present in the first month of life. The meconium periorchitis is also reported in children up to 5 years old, and USG plays a vital role in it. Both the masses and the calcification tends to resolve spontaneously without compromising the testicle. Thank you.
Thank you, doctor, for the nice presentation. Is there any family history of testicular torsion in the first child?
No, ma'am.
Because they said in literature, they said the testicular torsion can be credited in 10% of males. So we have to ask that also, but the other risk factors which you enumerated in your reason for a prenatal testicular torsion. Yeah, all the other things are not there. The floor is open for discussion. Any other question? If there are no more questions, we will move on to the third presentation of today. From telescoping to twisting, a surgical mystery in the abdomen. Dr. Shivani Armugam, with Dr. Prahada as moderator from Dr. Kamakshi Memorial Hospital. Over to Dr. Shivani.
Am I audible, ma'am?
Yes.
Good afternoon, everyone. I'm Dr. Shivani Armugam, DCH resident from Kamakshi Memorial Hospital. Today, I'm going to present topic on from telescoping to twisting, a surgical mystery in the abdomen. I am my moderator, Dr. Pragda ma'am, and I would like to thank my clinical lead, Dr. Rajeshwari ma'am, for giving me this opportunity. I would like to express my sincere gratitude to Dr. Arun Prasad sir, pediatric surgeon, for enlightening me with the valuable surgical insight. And a 2-year-old male child present to our pediatric ER with the complaints of 5 episodes of vomiting, the last episodes having streaks of blood since 1 day, and there is no history of fever, loose stools, or abdominal pain. But the child had a significant past medical history of 2 episodes of ileocolic interception within 1 month of interval, and which both are successfully managed with hydrostatic reduction. On arrival to a pediatric ER, the child was alert, tired looking, the airway was stable, breathing was normal, but the child had tachycardia, peripheries were warm, and CRT was less than 3 seconds. And systemic examination done showed her abdomen was soft, mildly distended, with bowel sounds were present and was no tenderness. CVS examination showed S1, S2 head, there was no murmur. Respiratory system, bilateral air entry present, there was no added sounds. Serious examination showed no focal neurological deficit. And USG abdomen done at a pediatric ER showed a Whirlpool sign with twisting of mesentery around the superior mesenteric artery axis, and SMV orientation appears altered, which highly suggestive of the midgut volvulus. And CCT abdomen done showed inversion of SMV axis relationship, duodenojejunal flexure on the right side, absent retromesenteric segment of the duodenum, cecum and ileocecal junction in the periumbilical region, twisting of mesenteric vessels along with the duodenum, causing the dilatation of the proximal duodenum and the stomach. These features strongly suggest the features of midgut volvulus with the proximal bowel obstructive changes. Here we can see the dynamic image of a CCT abdomen showing a valvulus sign.
மார்க் பண்ணுமா
Whirlpool sign. Birth history of the baby was the child was born out of a non-consanguineous marriage, spontaneous conception. The mother was GDM on insulin and hypothyroid on thyroxine tablet. And birth history, the child was term, born by normal vaginal delivery. Birth weight was 2.7 kgs and cried immediately after birth. And there is no history of NICU admission. Developmental history, the child attained appropriate milestones for age, and immunization history, the child was vaccinated up to age according to a national immunization schedule. And laboratory investigation, the total counts was 11,590 with the neutrophil predominant. Hemoglobin was normal. Electrolytes levels was normal. Clotting and bleeding time was also normal. And liver function test was normal. And with above investigation, the diagnosis of malrotation with midgut volvulus was made, and the child was planned for emergency exploratory laparotomy with proceed. Parents were counseled for the need of the surgery, and complications like ischemia, gangrene, and short bowel syndrome was explained, and child was shifted to OT. In Operation OT, the child under endotracheal general anesthesia with caudal block. Exploratory laparotomy was done with the right supraumbilical transverse incision, after which we are able to see the volvulus and latch band. And here we can say the intraoperative findings of the gut. Having this is the cecum, which is found to be in the umbilical region, and this is the image of the volvulus with lance band and the narrow base pedicle. And the intraoperative findings was cecum was noted in the umbilical region, and the volvulus of the midgut of 360-degree turn noted, and a narrow small bowel mesentery was noted, which looked like a thin pedicle, and the small bowel and large bowel was viable and normal. Latch band was present. Multiple enlarged mesenteric nodes present, largest of measuring 2 into 2 centimeter, and there was no obvious intrinsic obstruction noted. And this is the surgical video. It was taken in the OT while our surgeon was derotating the gut. And after derotating the gut, now we are able to see the latch band. This is the derotated gut. And which is also viable. And now we are able to see the latch band, which is obstructing the way. And this is the latch band. And the steps involved in the latch procedure was, first step is derotation of the volvulus done, which is counterclockwise 360-degree on full turn. Then the release of latch band will be done, and followed by straightening of the duodenum, followed by widening of the duodenocolic isthmus, then widening of small bowel mesentery, and with en passant appendicectomy. The small bowel, after these things, the small bowel will be placed on the right side, and the large bowel will be placed on the left side, followed by wound closure. So here is the image showing the normal anatomy of our intestines, and this is the image showing the malrotation of the midgut. Now we are able to see the with the latch. This is the latch band, which is compromised, which is holding the large intestine and small intestine and making the narrow base mesentery. And this is the image showing the malrotated gut, which is undergoing a volvulus, 360-degree volvulus with the twisting of the gut. And this is the image showing the after latch procedure, where we are keeping the small intestine in the right side and large intestine in the left side. So postoperative care, the child was kept on NPO for 5 days, started on partial parenteral nutrition, and supportive care was given. And the serial monitoring of serum electrolytes was done, and NG tube was removed on POD 5, started on oral feeds on postoperative day 5, and the full oral feeds was achieved, and the child was discharged on POD 7. Intraoperative and postoperative period was uneventful. And discussion. In order to understand the midgut, we have to understand the anatomy of the midgut better. So in anatomy of the midgut usually starts from the distal part of the duodenum after the major duodenal papilla to the proximal two-third of the transverse colon. And the midgut development usually starts from with 270-degree anti-clockwise rotation, which occurs in the three steps of rotations along the superior mesenteric artery axis. At 5 to 6 weeks of gestation, midgut rapidly elongates and forms a primitive loop, primary loop-like structure, and it will at which it goes into the umbilical cord. Since our abdominal cavity is too small to hold the rapidly proliferating midgut, and this causes the physiological umbilical hernia. Now, this is the primitive midgut, which is herniating into the umbilical cord, which forms a physiological umbilical hernia. And the part of the midgut above the superior mesenteric artery is called the prearterial segment, which forms the future small intestine. And the part below the And the part below the supramesenteric artery is the arterial segment, which forms the future intestine. And the first rotation, 90-degree clockwise, occurs at the site of umbilical ring at 6 to 8 weeks of gestation. After the first rotation, the pre-arterial segment will come to the right side and the post-arterial segment will come to the left side. And second rotation, 90-degree anti-clockwise, will occurs at the 10-week of gestation, where the reduction of the hernia takes place. It occurs at the umbilical cavity. So after the second rotation, the reduction of hernia occurs causing the prearterial segment gets overlapped by the postarterial segment. And third rotation, the final rotation, 90-degree anti-clockwise, will occurs at 10 to 12 weeks of gestation and in the abdominal cavity. After the third rotation, the duodenojejunal junction will come into the left upper quadrant. Duodenum passes posterior to the superior mesenteric artery, and cecum, which was initially in the subhepatic region after second rotation, will come and will descend into the right iliac fossa. And ascending and descending colon becomes secondarily retroperitoneal, and broad-based mesentery is formed, which usually prevents from undergoing volvulus. Now, this is the image showing the rotation, and this first image showing the herniation of the midgut into the umbilical cord. And this is the image showing the after the first rotation, the prearterial segment comes to the right and the postarterial segment comes to the left. And this D image shows us the after second rotation, where the prearterial segment is going behind the postarterial segment. And this is the final image after the third rotation. And this is the video for understanding the rotation better. This is the first rotation where prearterial segment goes to the right and postarterial segment goes to the left. And this is the image of the video of the second rotation, where the prearterial segment, postarterial segment is surpassed by the prearterial segment. I'll once again play the video. And this is typical herniation of the midgut. This is the first rotation, followed by this is the second rotation, where the prearterial segment gets surpassed by the postarterial segment. And this is the final after third rotation, the normal anatomical features. Malrotation. Malrotation of midgut is the most common anomaly of the midgut, and it is due to the incomplete midgut rotation with incomplete fixation. The key anatomical features is the duodenojejunal junction will not be in the left upper quadrant, and the cecum fails to descend, and it will be in subhepatic region, midline, or epigastric region with the narrow mesenteric base. There will be a presence of lax band, which is a fibrous band from the malposition cecum, and it will crosses over the duodenum and causing an extrinsic duodenal obstruction. The major risk factor of the malrotation is the malrotated gut undergoing a volvulus, which is a life-threatening. The incidence of the malrotation is 1 in 6,000 live births globally, with 30 to 60% usually present within the 1 month of age, and 90% of the symptomatic appears within first year of life. And incidence in adult is very low, that is less than 0.19%. And clinical presentation, usually the child present with bilious vomiting, especially in neonates, and may present with acute abdomen shock in case of volvulus. And the older children will present with intermittent abdominal pain, and bilious vomiting. And the main diagnostic method is the gold standard is upper GI contrast study, which will show us that duodenojejunal junction is not to the left of the spine. And USG Doppler shows a Whirlpool sign and SMV axis inversion. And we can also do CECT abdomen, which will show the features of malrotation and volvulus in present. And management is initial management is stabilization of the child. First, we keep the child in NPO and NG decompression, followed by correction of dehydration, electrolyte imbalance, and giving broad spectrum antibiotics and urgent pediatric surgical consultation. But definitive management is always a lax procedure. Indication is all symptomatic malrotation and malrotation with midgut volvulus, which is an emergency surgical procedure, and it is incidentally detected and also done in incidentally detected malrotation. And this is the image of the midgut volvulus gut, which undergoes an ischemia. And in case of asymptomatic malrotation, management is always controversial, but Nelson states that most pediatric surgeon is recommended to undergo elective LATS procedure because there is an unpredictable risk of volvulus at any age. And the postoperative care is gradual initiation of the oral feeds, and you always monitor for ileus, adhesive obstruction, and short bowel syndrome if volvulus with ischemia present. And the possible complications after surgery is early and immediate complications are gangrene of the small bowel, perforation or diffuse peritonitis, septic shock or multiple organ dysfunction syndrome. Late complications is short bowel syndrome, severe malabsorption, pernicious anemia, and adhesive obstruction. Thank you.
Thank you, doctor, for the excellent presentation. And the two surgical problem in the same child. And what are the reasons for interception and recurrent this child? Are you able to find out any cause for recurrent interception?
Malrotation can also cause recurrent interception.
In this child, what the child is caused, are you able to find out any cause for recurrent interception which has happened before in this child? You have done a CT and everything. Is there anything pointing towards that?
Hello, ma'am. This is Dr. Arun Prasad. I'm a pediatric surgeon. I'm the pediatric surgeon for this. I would like to take over this answer. Yeah. Hi, ma'am. Hi. Regarding malrotation itself is one of the reasons which will cause recurrent interception because the ascending colon is not fixed at all. Ascending colon is if you notice it's a completely retroperitoneal organ. It's not a mobile organ. In case of malrotation, it is not completely fixed. A simple mesenteric adenitis can cause recurrence of interception in that case because the whole intestine is completely mobile. So the recurrence of interception itself had given us a clue that something else is going on inside. I initially suspected probably the usual suspects as Mickels or any other lead point, but this was a little unusual to have a malrotation itself as one of the cause. And there is a terminology which we call it as WAS syndrome, WAUGH, WAS syndrome, where you will be getting the malrotation, interception along with malrotation, presenting right as a mass, right, even up to the rectum itself. Since the whole thing is completely mobile and the interception can progress even up to the distal part of the sigmoid colon and rectum also, which is not possible in a normal fixed bowel, which can happen only up to hepatic or max of transverse colon.
But still having hydrostatic reduction has been done. So probably maybe one of the, wider arrangements you can do with close interaction, probably. That's,
yeah, the initial 2 times we did the hydrostatic reduction under ultrasound guidance.
So can interception can happen in utero?
Ma'am, can you repeat the question?
Can interception can happen? Interception can happen in utero.
In utero, it is possible, but we don't have a proven evidence for that. But usually, when it happens, it can present. It usually undergoes torsion, and finally, it can end up resulting as a intestinal atresia. That is how the presentation usually happens. We will not know whether it happens as an interception or any vascular accident. We don't know. And once that becomes gangrene or anything that happens intrauterine, it finally presents as an intestinal atresia.
Thank you, sir.
Thank you.
And so we need to any other heterotaxic syndromes in the child. Otherwise, child is otherwise fine.
Yes, ma'am. Child is otherwise fine. There is no heterotaxic syndrome since the liver and spleen, everything is all in the normal position. And only the rotation part of the was having an issue.
Thank you, sir.
Thank you so much.
Any other questions to the floor? Thank you so much. So if there are If there are no other questions, we'll go on to the last presentation of this day. I have resolved the crime. Okay, lessons from emergency room. Dr. Prema Lakshmi with the Dr. Niveda from Sri Balaji Medical College Hospital as moderator. Over to Prema Lakshmi.
Yes, ma'am. I'm not able to share the screen, ma'am. Ma'am, ask someone to stop screen share. I'm not able to share the screen.
Dr. Shivani, kindly stop sharing your PPT. Dr. Shivani? Can share simultaneously. Dr. Prema, can you start sharing? Dr. Prema, you're having some issues with the audio. Prema, if there is multiple devices switched on at the same point of time, you may get so much of echoes like this. You're not able to hear. Keep the volume of other devices on.
Ma'am, go. Now
Dr. Prema, we are not able to hear.
okay, ma'am.
Dr. Prema, if it's possible, you can go to some other's device and then you can start presenting. The slide has been shared. You keep yours switched off and you can use some other mobile or some other thing to share.
Hello, ma'am. Now audible, ma'am.
Yes, pa.
Yes, audible.
Prema, it's still not audible, ra. Dr. Prema?
Dr. Prema, shall we plan for next edition as the first topic? If technical issues
Hello,
are
ma'am.
there,
Hello, ma'am. Now I am audible, ma'am.
yes, ma'am. But when you are sharing the PPT, echoes are coming, doctor.
Okay, sir.
Now it's clear actually. So once you are sharing,
You
I
have
think
it in the
two
phone.
outputs are working.
You do it on the phone, it's in the slide and then you just change. Okay, ma'am. Check, check. இல்ல. His phone is off already. He's not personal. She was getting demo room. That side next to that therapy room. Play பண்ணி. இல்ல மேம் ஷேர் ஸ்கிரீன் கொடுத்துறேன் மேம். இந்த ஸ்கிரீன்.
Dr. Prema, if there is still technical issue, can we post for the next month CPT meet as your first presentation?
First presentation.
Hello, ma'am. I'm audible, ma'am. Ma'am, we are started in the issue, ma'am. 4 minutes, ma'am.
That's what. If that is the case, can we have the meet? I mean, the presentation for the next meet. I'm just asking you because it's already 1 hour and more.
Phone control, champions. We don't have a slide. PPT is basic. PPT share make it on sound alone. Understand is okay. What are some?
Ma'am, Kritika ma'am, are you available?
Yes, ma'am.
Ma'am, Kritika ma'am from Balaji.
Hello, I'm Dr. Sundari calling. We'll have it next time.
Good afternoon, ma'am.
We'll have it next time then. Some
Okay,
problem
madam.
with the net connection in our area.
Ma'am, good afternoon, ma'am.
Good
Thank
afternoon,
you.
Balaji.
Good afternoon, ma'am. Okay, madam. No
இல்ல
issues.
இது ஏதோ கனெக்ஷன்ல ப்ராப்ளம் இருக்கு.
First topic we will put, ma'am. No issues.
ஓகேப்பா.
Thank you, ma'am. Thank you.
தேங்க்யூ.
Thank you so much, ma'am.
ஓகே.
Shall we close that? Shall we close the session?
Yes, ma'am. Yes.
I thank all the participants who have
அவங்க
presented
க்ளோஸ் பண்ணு.
You just have it in a moment. Only we will send it to mobile.
Thank you, ma'am. Thank you, sir.
Thank you so much, one and all. Thank you.